So far in this presentation, we've noted the background of clinical reasoning and why it's so important, and the errors that can occur during faulty reasoning. In this next presentation, we're going to look at illness scripts and how this relates to memory. Illness scripts and memory are closely associated, and as we've seen previously, short-term memories are encoded and stored in our long-term memory. And this is true for illness scripts as well. And the way that this works is that as we are seeing patients, we're coding their signs and symptoms into scripts that we can then use on current patients to almost predict the future or the course of the disease process, and therefore inform our clinical decision making. So what are illness scripts? Illness scripts are essentially knowledge that we've bundled into networks, organized networks within our brain. And during illness scripts, we're integrating new and old information and forming a new script or a set of instructions of what to do and what to ask when we're seeing patients. These scripts are not written in stone, and they are actually refined through time. They're refined through experiences that we have with patients, in that if we see a patient with similar signs and symptoms, we often recall a patient that we'd seen before, or the first patient that we'd ever seen before with those signs and symptoms. They're also refined through learning, and this learning happens when we see a patient with signs and symptoms that aren't necessarily the same as what we've seen before, or new signs and symptoms or tests that we've become accustomed to. Illness scripts are essentially a set of instructions going forward to predict almost what will happen in the management of the patient in front of you based on your previous experiences. Illness scripts are actually based on a theory called script theory from psychology. And script theory is that in everyday life, we form a script almost like a theatre script or a movie script, in that when we go somewhere, we're aware of our surroundings if we've been there before, and we're able to see subtle changes. Imagine that you're going into a restaurant that you know very well. You're almost able to know what's on the menu, where the seating will be, where the restrooms are, where the bar is. You're aware of the waiters that you place the order with, and you're aware of what the food will look like, or even taste like and smell like if you've had it before. However, sometimes when you go into a restaurant, it's been remodeled or renovated and things have been moved. And what's happening here is script theory, in that you're now adapting your script that you know to the new experiences that you're having. And this is exactly the same as when you're seeing a patient, in that you're aware of the signs and symptoms that you've experienced in the past and how they relate to a clinical diagnosis. But sometimes you get a patient that has a new symptom or a new sign, and therefore your script is constantly becoming longer and more refined during the more encounters that you have with the patients. So illness scripts in relation to medicine or patients are essentially just a list of interconnected events that you've experienced in the past. They help you predict how events may play out in the future by relating those past patients you've seen to how well or unwell they've become in their management plan, and what kind of things and interventions have helped them. So they allow us to assess for inconsistencies and discrepancies, in that in some patients that we can see consistent things across symptoms, signs or examinations, but they allow us as well to compare the discrepancies to what we already know, which is important to pick up those patients where we're building a differential diagnosis where things might not be essentially clear. And they help us to recognize patterns in those symptoms, in recognizing the common causes of a disease, but they also help us identify some of the irregularities, which are then important to building the differential diagnosis and sometimes taking us away from a potential diagnosis that we could have made in error. So if we think in terms of decision making, when decision making occurs quickly and effortlessly, and we recognize patterns, we can say that our script is complete. No more additions need to be made and we can make the diagnosis. But sometimes we find a mismatch between what we predict the patient to have in terms of symptoms and signs, and often the data that we get from the patient from the history and examination, we're often surprised that these don't quite add up to the script that we have in our head of these signs and symptoms. And this initiates within us a search for an explanation, i.e. asking more questions and taking a more focused history. In terms of memory, this goes some way to explain why some clinicians are able to make that diagnosis at the end of the bed, where we think that they almost plucked it out of thin air. What's happened over the course of their clinical career is that they've seen more patients and been able to relate those patients' signs and symptoms to their illness scripts. In short, what they've had is more patients in their short-term memory that have been encoded into their long-term memory, where illness scripts are stored and then retrieved into short-term memory. In your assignment, this is useful to think about if you're actually an inexperienced clinician and struggling to come up with differential diagnoses, or finding that your diagnoses aren't quite right, or you don't know enough. You can strongly relate this to script theory and the fact that because you're inexperienced, you need to build on these scripts and see more patients. Conversely, if you're an experienced clinician and find that you're acting by intuition, you might have a patient that you've already got quite a definitive illness script of, then this is something that you can critically analyse within your assignment, relating this to intuition. So let's consider a patient that you see who comes to see you and they complained of a headache and discomfort. As we can see, the patient's clutching the right side of her head and appears to be in some discomfort. She tells you that a headache started slowly, and what you may be thinking in the back of your mind now, basing this on an illness script, is that she might have a migraine, and your brain's working hard to locate all that you know about migraines. Essentially, right now, you're accessing your illness scripts. This script that you're accessing is actually the interconnected clinical knowledge that you've accumulated through all those years of experience. If you didn't reach the diagnosis or differential diagnosis of migraine, it may mean that you've not seen that many patients present in this manner, and this is where you need to build on your illness scripts. So if we look at script theory, many illness scripts can be activated from early prompts. If we look at some of the prompts that we were given, the verbal prompts were that the headache started slowly, and the non-verbal was that it was a young woman clutching the left side of her head. All of these are strongly associated with a patient having a migraine. These scripts subconsciously frame our expectations of the patient in front of us. The question arises then if we should take these symptoms at face value, diagnose this patient with a migraine, or explore further. Something may mismatch with our illness scripts, and we may opt to ask about the severity of whether the headache's pulsatile, if there's any light sensitivity, or if it's relieved by sleep, and this should also reinforce a diagnosis of the patient having a migraine. Because these scripts are framed by our experiences, as we gain more experience, we're able to gain more illness scripts, and we're able to refine them, and so we have more in our long-term memory to relate the signs and symptoms to a diagnosis of the patient that we have in front of us. And this is the reason that you see experienced clinicians pluck those diagnoses from the air. It's really simple. They actually have more illness scripts than you, and they've seen more patients. And they're strongly able to relate those past patients that they've seen with their signs and symptoms to the one sitting or standing in front of them.